So I'm here today to talk about precision oncology application. The future is now. And we just heard the talk, and you have ample message coming through that talk that we have to learn and apply. And even though I'm wearing pink, I am not going to talk about breast cancer. So that's going to be a little bit of a switch from what you are attending. And hopefully I will be able to retain your attention, because this crowd may be seeking breast cancer discussions, and I'm actually going to pull in all kinds of cancers here because of what I said. I practice precision oncology, and I identify myself as a solid tumor oncologist. In my previous life, I used to be early drug development person, a phase 1 person, head and neck, lung, upper GI. But prior to that, during my fellowship, very much a breast follower. So, you know, this man is leaping from past to future. It could have been a woman, because I identify with that. So I put up this picture because I feel we need to, in the community, and this is, I'm appealing to the general oncologist who practices in the community, who feels the limitation of the subject. But that's how we have to go about it. And I say this often, probably the science of precision is not going to be perfected in my lifetime, but what we could do today with an imperfect science and imperfect testing and imperfect application of therapy is what we are setting out to do, and that's what we have to achieve. All right, so this is me, and these are my disclosures. Just pressing that. Okay, I think I'll just go with this because we don't have time. So very recently, I wrote an article to the same effect in the Times of India. And in this article, I said the future of cancer care. But as we look at the applications that were just discussed, if you miss out on that, you really are missing it in real time. So the future is actually now. You have to really watch out and look at the application. So I also have a HER2 story, and I thought I must say that. When I was a resident at Sloan Kettering Cancer Center way back in 2002, 2003, my first project, which was totally bewitching, was a 2,000 patient data collection on HER2 positive patients, where this drug was really transforming the end result outcomes of these patients, and that was trastuzumab. Fast forward to my first faculty position at Dana-Farber in Boston, where my first project that was given out to me was HER2 positivity in salivary duct cancers. And this is a small publication, one of my seminal ones, where we looked at HER2 positivity in salivary duct cancers, and those salivary duct cancers that are HER2 amplified actually have similar results as breast cancer, and have patients who are with advanced disease who are surviving the disease on trastuzumab or HER2-directed therapy. And then this, one of my seminal cases where an advanced head and neck patient with oropharyngeal cancer was found to have HER2 positive disease or HER2 amplification, and we gave trastuzumab to this head and neck patient in 2009, when a 40-gene panel had just come out as a part of a research initiative at the center. And it was transformative because you changed the outcomes of the patient by giving a drug that was never thought of in that particular disease. And you see the outcomes really revolutionizing cancer care. And this wasn't just one case. Through the Early Drug Development Center, things were happening in lung cancer. ALK was coming through, ROS was coming through. You saw these patients heavily pretreated with disease everywhere, brain, bone, liver, what have you, and the disease transformed by giving these drugs that were very, very pathway specific. Then comes fast forward into NCI match, and I was selected to be one of the chairs of one of the arms of this study. This was arm B, where again the HER2 pathway, HER2 mutants other than breast cancer. So we're not talking HER2 amplification, we're talking HER2 mutation, and how a drug that was till then thought to be a lung cancer drug was utilized, afatinib was utilized in this particular arm to see if HER2 mutation would respond to afatinib. And NCI match, as you know, is one of the most ambitious seminal efforts in precision. I don't say that it was actually foolproof, and today you have many a criticism for how it was designed and how it should be done and things like that, but it was one of the most ambitious efforts in the precision world, where you saw pathway-directed therapy in heavily pretreated patients where you did not expect the pathway and you utilized a drug outside of a particular organ system in another organ system, many, many times organ agnostic. So why hasn't precision come into focus? Why hasn't precision made it into frontline therapy? Why isn't precision the only thing that all of us are practicing? That's because I think, and this is a known fact, and this is actually a slide from Accenture presentation, unfortunately, it is one of the areas where we get highest therapy failures. 80% of oncologists believe precision will be an important clinical environment within 5 years, but if you really look at the representation, only 14% of physicians come to molecular tumor boards. 18% are actually routinely used in clinical trial decision-making, and 40% of therapies are actually leading to failures due to genomic alterations. So what is happening in India, and I can probably equate it to what may be happening in Bangladesh, we are just learning to organize ourselves. We are just learning what is the pathway-directed therapy, what are the guidelines. So this pile is now becoming this pile. And then precision wants to bring it all together, because you're learning from breast and bringing into GI, and you're learning from breast and bringing into lung, and you're learning from lung and bringing into head and neck, and it's all a hodgepodge. So you don't know where to wear the sock. You got to wear it in the foot, or you're going to wear it on the head. And that's a challenge I face every day. What about the organ-agnostic pathways? You talk about RET, you talk about NTERK, you look at MSI high, you look at TMB. Where are you going to apply that? Are you going to keep the TMB for where it was initially described, like the colorectal cancer, or are you going to bring it in a sarcoma patient, or are you going to use it in a lung cancer patient? You know, the pathways are intermingling, and it becomes very confusing for most of us who are trying to do simple oncology application of these pathways and these techniques. And then comes this whole thought process from 2020, the cancer moonshot, and the avalanche of immunotherapy and the biomarkers. And I put up this slide because this is one of my patients, one of my initial patients who was treated with immunotherapy way back in early 2000s. This patient, when I was beginning to take over this patient, refused chemotherapy, advanced squamous lung cancer with a Christmas tree pattern of metastasis. The patient refused chemotherapy. Now, we all talked about a year and a half of survival. This patient went all across Yale, Columbia, MSKCC, Dana-Farber, saw everyone, and then came back to me for treatment, said, I am only going to take immunotherapy. I got a call from one of the leaders at Columbia. I said, Sewanti, this patient is not going to respond to immunotherapy because it has no biomarkers for immunotherapy response. The patient got 4 doses of immunotherapy drug, developed pneumonitis, almost got admitted, we didn't have to, recovered from that, remains disease-free even today. So imperfection of biomarker accountability is also a reality, and that really shakes us up. What are we really following? What are the biomarkers that we are supposed to pursue? And then, of course, there's lack of data. Is the data, or all the data that we are getting from the West, can we apply that here? Do we have our local data? Are our patients going to respond the same way as we expect the responses and the results coming out from the West? And then, of course, this is a slide from my guru, I say Dr. Razel Kurzrock, where it is, genomics is just the tip of the iceberg, because we are still discovering many, many layers to cancer behavior. When we talk about the layers, I'm just beginning to understand a lot of these terminologies, leave alone the application. Then I go back to the precision trials and also the heterogeneity of these trials. Some trials are using some kind of biomarkers, the other trials are using other kinds of biomarkers, and there are trials that are evolving. None of these trials appear to be using all of them. Then there is a seminal trial from India that comes in and looks at all these put in together, which I'm going to show in a second, sorry. And then there is this iPredict study, which I follow a lot, where they used another type of calculation, something called a matching score, and showed that if the patients had a match to 2 pathways or more and got 2 pathway-directed therapies, they did better. So this is just one example of how precision is being understood and applied by some of us. And this field appears to be still evolving, where we are trying to understand how to really apply the pathways that we discover in the multitudinal tests that we are doing in our patients. When we get into each patient is special, and we know that in precision. When we get into the results of each patient, are we catering to that particular patient? What about that one patient? What about N of 1 application? And that's what, if precision is being practiced to its reality, is it N of 1 that we are pursuing? Then comes in drug sensitivity and the fact of tumor heterogeneity. All of us deal with tumor heterogeneity all the time. I have been a part of certain studies. In Colombia, there was a master regulator gene by Andrea Califano, and then there was this reverse engineering with mouse avatars and cell cultures, and where are these today? Do we have the PDX models? Are they ready? Does it address tumor heterogeneity that we see all the time in our patients? How do we address these issues? Is there a trial, and this is the trial that I was talking about, multi-analyte testing, chemosensitivity included, genomics, transcriptomics, and proteomics, all of that within India, 150 patient trial. And if you see here, this is a patient who received chemosensitivity-based chemotherapy. Pemetrexed is never given in head and neck cancer, and 2 pathway-driven drugs. And you can see the result, a picture's worth 1,000 words. Lastly, the message that came out in one of the recent publications by the leaders in precision oncology, cancer, an ever-evolving disease, a 9-headed hydra. And the group that published this also published this, where blind man and the elephant, where each of us, when we assess a cancer, we may actually be studying that patient from what we looked at, from what we got, and not actually what the patient is. And when we have such a big heterogeneous presentation, how do we put it all together? And that's why I said imperfect science, and probably not going to really become perfect in my lifetime, but what am I doing to try and get a control of this? So this is the structure that I follow. I've established a precision oncology center where, as a community oncologist, I'm trying to really piece it together for myself and the people who work with me. So we have a precision clinic we have genomic tests that we do with lab partners. We have rare tumor clinics where we understand the rare tumors a little better. We have pediatric precision clinic. We have clinical data gathering. We do our own molecular pathway curation, hereditary genetic counseling, and then we discuss our cases in multiple different tumor boards. I have weekly molecular tumor boards where the young leaders from Bangladesh have participated. Dr. Arif has joined in to present his cases. Impact India International, I run a national, international level molecular tumor board, and I also am a co-founder of a company called ILON Precision Oncology with my good friend, Dr. Sendurai Mani from MD Anderson Cancer Center, which is a concierge service in trying to get more light onto certain very, very tough to treat cases in precision oncology. So the bottom line is we have to try and put it all together in this very, very complicated times. Not every pathway is HER2. And it's really heart-wrenching to see a lot of these patients coming in with truckloads of genomic information already done. I see patients in third, fourth, fifth line, a lot of genomic reporting already done, but people haven't really applied because we don't know how to apply. And that's where I think it is time for us to come together and put our minds in unison for the application of precision oncology. Now I'll ask how much time I have.
Oh, you have remaining 2 minutes.
2 minutes. So I'll just show you some of my cases because I had plenty, but I don't think I will be able to show that. So this is a 50-year-old rhabdomyosarcoma, advanced rhabdomyosarcoma patient. Rhabdomyosarcomas are actually cases that we see in pediatric and young adults. So a 50-plus-year-old doctor in India, a general practitioner, sees 200 patients a day, if not more. Comes in, advanced disease, and this is the sequence that has been brought in. I don't know. I presented this case, multiple tumor boards, couldn't really get an answer. While researching, I found an article by Vivek Subbiah and the same group, Razelkar's Rock, and similar pathways. You have CDK4 and you have FRS2. And if you go back to the previous slide, you have the same thing. And so this patient, their patient responded to lenvatinib and palbociclib for 51 months. I didn't give my patient immediately the therapy, but after 3 lines of chemotherapy failure, the patient comes back to me right now responding to both lenvatinib and palbociclib titrated together. This is a patient, multiple lines of therapy failure, triple-negative breast cancer, everything given, including immunotherapy and chemotherapy, which you know only 1% of developing country gets. But this patient found to be EGFR amplified, 46 copy numbers, and treated with EGFR inhibitor, a mAb. Nimbutuzumab is available in India at lesser cost, and gefitinib. And you can see that now it's completely dried out, even better than how this picture is looking. And this is a case of an advanced adenocarcinoma stomach that came to me on workup, and hearing the story, it appeared she was BRCA positive. And she came with multitudinal nodules, inflammatory nodules all across the body. On examination, she presented to me as her recurrence of breast cancer was presented as triple-negative breast cancer, but she had a low hemoglobin test, advanced gastric, and BRCA positive, MSI high. Treated her with chemotherapy, immunotherapy, but then in maintenance, do you give an olaparib or do you give an immunotherapy drug? Continue the immunotherapy for maintenance. And what do we find? MSI high, irrespective of what caused it, you could still respond to immunotherapy. This patient, 2 years later, is completely fine. And so this is how she looks now. 2 years later, all of disease gone. The BRCA was definitely contributing to the MSI high status. and the patient responded to maintenance immunotherapy and now off therapy as well. So what I wanted to tell you at the very end, and actually that is the message that I would want to leave you with, and for that I think I'll have to scoot over some of the slides. This is my last patient. So this is an oral cavity case with locally advanced disease, progressed through primary treatment. So surgery, progression while waiting to get radiation, started neoadjuvant chemoimmunotherapy, responded initially, progressed, sequenced him. If you see here, he has HRAS, he has EGFR, he has PDGFR-A overexpression, so not just genomics, but transcriptomics, proteomics, all of that utilized, including chemosensitivity. Drug was changed, the chemotherapy drug was changed, immunotherapy was continued, and a trametinib, lenvatinib was added at a low dosage. This patient had complete response, and this is post-second surgery and prior to starting the radiation. A curative resection was able to be possible in this patient with precision management. So, what do we have to do? As practicing precision oncologists, we have to really build the basics. We have to think beyond the routine. We have to reimagine the medical education so that our teams that are coming up, the young generation that is coming up, really is motivated to detail analysis of our molecular pathways, is armed, is empowered to do that as we go along. Minimizing complexity, coming in together, look at each patient as a special case, and piece it all together. Targetable mutations, other biomarkers, consider drug sensitivity testing, reverse engineering, because future is now. And at the end, I would say, are we slaying the Hydra yet? And in this, I just point out that this picture is gender balanced. There is a woman in there. So I started out with a picture of future is now with just a man, but you have, and that's actually a publication by Dr. Razel Kurzrock, and you see that the man and the woman are fighting it shoulder to shoulder to slay the Hydra. And that's what we have to do. I see many, many women here and more power and force to all of us. And with that, thank you very much for helping me share my story, and I hope I'll be able to motivate the crowd out here to practice precision as a science that is not perfect, is developing, but it could really help save lives, as we learned from the talk before me. If we don't really figure it out and apply, all the application is going to fall short, and we are going to lose out on lives that we could save. Thank you so much, and it's an honor to be here this evening.